Okay. Purva, shall I start?
Yes, sir.
Okay, right. So good evening to all of you. As usual, I will start with a short case first.
Yes, sir.
Yes, sir.
Yes, sir, we can.
I'm starting. I'm not able to see the screen now. You can, I think, Purva, you can stop the sharing of your screen. Purva, you can stop the sharing of your screen, please. Then only I can share.
Yes, sir. Actually, I have not shared. I'm checking. Yes, yeah.
Yeah. Right. I will try once again, just 1 minute. Okay. Can you see my slide now?
Yes, sir.
Yeah. Okay. Right. Right. I will. So, as usual, I'll start with a short case first. This is a story of an 18-year-old man who noticed weakness of the right hand in the form of inability to write when he got up from sleep 3 days back. He said he was unable to lift his middle 3 fingers. No numbness or paresthesia. This is a video of the patient.
ഈ മൂന്ന് വിരലും ഇത്ര പോകുന്നുണ്ടായിരുന്നു.
He said unable to lift his
ഈ മൂന്ന്
അത് പോകുന്നില്ല. മറ്റത്
ഇത് രണ്ടും കറക്റ്റ് ആയിട്ട് മൂവ് ചെയ്യുന്നുണ്ടായിരുന്നു. പക്ഷെ ഇത് മൂന്നും
able to
ഇത്ര
extend the index finger and a little bit. Maximum weakness for the middle 3 fingers. In fact, all his fingers are mildly weak, more for the middle 3 fingers. Long finger flexors are normal. Flexor pollicis is long as normal. Extensor pollicis long as is weak. Good. Extensor carpi radialis long as is weak, normal. Extensor carpi ulnaris is markedly weak. On plunging the hand, the hand goes into radial deviation. Brachyradialis is normal. Supinator jerk and tricep reflexes are normal.
ഈ മൂന്ന്
So yes, weakness of extensor digitorum, extensor mainly for the middle 3 fingers, extensor carpi ulnaris, extensor digiti minimi, mild weakness of extensor pollicis longus and brevis and extensor indicis. Normal for the triceps, brachyradialis, extensor carpi radialis and other muscles. DTR normal, no sensory findings. So, where is the site of lesion? What is the probable diagnosis?
Sir, post-intraocular lens.
Okay, very good. Now, it's a straightforward case. Where is the site of lesion in this patient?
After the radial growth.
Sir, extensor carpi radialis longus, extensor carpi radialis brevis, supinator muscle power, you have not told, sir.
Yeah, the extensor carpi radialis is normal, no? I told that you showed the video. I think I'll show that once again. I'll show that part once again.
ഈ മൂന്ന് വിരലും
Just now I'll come. Digitorum normal, flexor pollicis is normal. Extensor pollicis longus is weak. Now look at this now. I'm going to examine the dorsiflexion. That's extensor carpi radialis normal power. Extensor carpi ulnaris is weak. Okay. Triceps also is normal.
ഈ മൂന്ന്
Supinate is also weak, but I did not show that here. So,
Site of lesion just distal to the supinator, sir, at the origin of post-interosseous nerve. Because radial nerve gives branches, a deep motor branch gives supply to the extensor carpi radialis longus supinator, followed by extensor carpi radialis brevis, sir. So after that only pin comes, sir. So
okay, very good. So why the reason for hand going into the ulnar radial deviation is what? Because of the sparing of the extensor carpi radialis, correct? You know, when you it goes into radial deviation.
Yes, sir.
That is because of the sparing of the extensor carpi radialis. Perfectly right. You are perfectly right. That's in post-interosseous. And what's the usual site of post-interosseous palsy?
supinator syndrome.
This is supinator syndrome. Okay. So what do you expect in the nerve conduction in this patient?
Conduction block at the level of in between the distal to the spiral groove and the extensor and distal.
Yeah, that depends upon
points of stimulation, sir.
Yeah, that depends upon the site of pathology. Let us see. This patient had normal conduction. No block anywhere.
Early NCS, sir.
No, it was done later, 2 weeks later.
Radial snap, sir.
Radial snap, I'll show you. That is radial snap normal.
Maybe in the proximal brachial plexus even, because of selective vulnerability for the affection.
No, so it is exactly fitting with the post-interosseous nerve distribution. So it's most likely, theoretically you are right, but all the muscles almost marked weakness in that distribution. Even extensor carpi radialis is paired. That is required for a lesion in the brachial plexus.
Here, the extensor indicis is the one which is checked for this now. That was not.
Extensor indicis is also affected, but mildly affected.
Yeah, it's only partially affected. That is
Partially affected.
Checking is from there, you know. CMAP is from.
Yeah, but that's correct. That's now again normal.
But post-interosseous usually NCS will be normal.
Yeah, it's supplied by it can be affected if it is significantly, extensor indicis significantly affected. Here, extensor indicis is not affected. It is affected, but only very minimally. Okay, what you said is all correct. So this is
above the radial elbow, sir.
It can be above the elbow. That's the reason I brought the patient. I'll show you. So normally what you think it's a post-interosseous nerve palsy without this is called ulnar wrist drop. That ulnar wrist drop means the muscle supply in the middle, the hand goes into radial deviation. The ulnar part is weak. That is called ulnar wrist drop. And the usual site is at the supinate restode. That is the supinate syndrome. Sometimes you remember that this kind of a pattern can also occur due to lesions in the spiral groove. If you look at this patient's history, he was lying on with the hand, just like it was Saturday night palsy. He was keeping his hand on the sofa like that and he was sleeping. Next day morning, he showed that. He never had any pain in the region of the supinator region. Just something like a classical radial pressure palsy. That is very odd that is the point which search the literature to find out such thing can occur or not. So this particular article, the clinical manifestation of pin lesion includes ulnar wrist drop and finger drop, as you already seen. The cause of pin is often thought to be a compression of the supinator muscle, referred to the supinator syndrome or the posterior inductus nerve syndrome. This is where the arcade of force, where the posterior, you can see the posterior, nerve going behind the arcade of force, where it's likely to get compressed. That is the usual site of supinator syndrome. But this article shows that sometimes even a pressure pulse in the radial groove can have a selective vulnerability for these pin muscles supplied by the pin distribution. This particular article, the patient presented with pin palsy, but he had a hyperintensity in the radial nerve, the radial groove, due to pressure palsy. That is shown there in that picture. Just our patient also had something like a pressure palsy in the radial groove. Now, whatever it is, your localization is perfect. It is posterior inductus palsy, usual site is supinator. But remember, this can also occur sometimes due to pressure palsy in the supinator region. Okay. Why it is not picked up in the EDS, picked up in the extensor indices? Because your stimulation is proximal to that. But stimulation is in the radial groove. We are stimulating the indices in the elbow. Okay. Any questions before I go to the proper long case?
Sir, we usually in radial nerve we'll have 4 stimulation sites, sir. One
Yeah,
in
that,
the
right. You already said that should be done. Because above the radial groove, that should be done. But here it's only done with 2 sides. Below and just above there.
okay.
Because nobody diagnosed the lesion in the radial groove. It was diagnosed as supposed to be a pin palsy.
Okay, sir.
Okay, this is a story of a 27-year-old lady presented with the history of blurring of vision or looking to the right for the last 4 days. She was perfectly all right 4 days prior to that. On leading question, she gave history of diplopia on looking to the right. I asked her whether the blurring is due to the diplopia. I mean, yes, she said it disappears on closing one eye. So that made me convinced that it's likely to be diplopia. Even though she did not say diplopia, more likely diplopia. No other complaints. She used to work for long hours in the laptop, being an IT professional. And for the 4 consecutive 2 days prior to the present complaint, she was working extra time. And husband was telling that she's used to watch movies in the mobile phone in the bed even at night. So that's the story. Okay. There's no other story. Only thing is a blurring of vision looking on the right side with binocular vision. Okay, this is the video of the patient. Looking to the right side. Checking the ocular movements. Left side. Again, right. Up and out. Then up and to the left side. Down and to the left. Down and to the right. But only keeping on looking to the right side, if on some restriction on the left eye. Again, guys, look once again, looking on left to the right. Let's ask her to keep on looking to the right side. So appeared not very convincing, appeared that left eye is not adducting as much as on the abduction on the right eye. May not be correct. That's a thought like that, may not be correct. Okay, now go to the rest of the examination. Then this is the one, this is on looking to the left side. And this is on looking to the right side immediately. It is almost parallel only, no disconjugation. But ask her to keep on looking to the right side. It appears slightly some adduction failure was observed. Not very convincing. That's the thing observed. So rest of the examination was normal. I will just pass through that. Don't bother. Plantar was downgoing, sensations were all normal. Gait was also normal. She never complained, had any other complaints. Anyway, completion sake, I complete the examination. Normal. Then her gait was also normal. So, what is a diagnosis now? I have provided only limited data. We can only guess. What do you think at this point of time? What could have been the cause of his diplopia on looking to the right side? Okay, let us see this. So what I thought, yeah, please, yeah.
Is there any fatigability, sir?
Now I'll come to that because that's the question I had. Because this is the exact thing I wanted to show you. See, this is immediately on looking to the right side. It appeared almost no disconjugation. But keeping on looking like this is what I observed. Mild fatigability may be there because the middle part of the sclera is visible on looking for a prolonged period of time. So that's the thing I had. Okay, let us see. Now, there is mild disconjugation looking to the right side, especially when she is asked to keep on looking to the right side. So is it due to failure of adduction of the left eye? And I also found some ill-sustained nystagmus looking right side, which is not very obvious. Only 2 jacks was there on the right side. So is it left middle rectus weakness, and what could be the cause? If at all, there has to be some middle rectus weakness. So what could be the cause?
They rule out myasthenia.
Right, myasthenia. That's it. The first thing you have to rule out is myasthenia, especially when the patient goes on getting it on looking to the right side.
So one doubt, sir.
Yeah, please.
Sir, here there is adduction is not maintained, sir. So it could be possibility of UMN also, like an INO.
No, INO is possible. INO, again, fatigability.
Adduction.
Adduction lag is there, no?
Adduction lag is there, sir. Still, INO can be considered.
Yeah, it can be considered. But the only point is that usually INO what happens, adduction lag. But here what happens is that when the patient is fully adducted normally, but it fatigues and come back. That's what I showed earlier.
So in early INO also, we cannot directly visualize. Only in OKN tapes, the adducting saccades will be slow.
Yeah, correct.
So,
that will find. Yeah, that part I agreed. But that saccade, the fast saccades will be slow in INO. That will perfectly right. But here, what is not what observed on looking at checking ocular movements, the adduction range is normal, but the full range is there. Keeping on looking at the right side, some going laterally. That's all I observed. That is not the one you see in INO.
okay.
You got the point. The
Yes,
adduction part should be slow. That part I agreed. But once it goes down, it will not come back like that.
Yes, sir. Okay, sir.
This looks like fatigability.
Yeah, something like a fatigability. It may not be correct. Sometimes, he manifests late in the skin also, this can occur. Because when the eyes get fatigued, the diplopia will become manifest. See, in manifest late in the skin, what happened mean? The patient's got mild heterophoria, latent squint, which will be compensated by your visual divergent system. When you strain your eye too much, the eye get fatigued and the squint become manifest. The heterophoria become heterotropia. So that's also another possibility when you get such a phenomenon you have to find out. At times you find orthotropia, at times even heterotropia, because when the eye is fatigued only, you will find the disconjugation. So these are the 2 possibilities, left middle rectus weakness and manifest latent squint. Okay, let us go step by step. So what could be what else you need now? One is a concomitant squint, the other is a rail weakness, paralytic squint, mild paralysis.
The cover eye, yes.
Okay, well, adduction testing, no?
Yes.
Because, yeah, adduction testing to find out whether squint diplopia is due to manifest latent squint or due to paralysis of the muscle. Here, the left medial rectus, correct? In what happen, induction will be perfectly normal in squint, in a latent squint. Okay, latent squint and manifest squint also it will be normal because you only focus with the one eye. The extraocular movements are normal. Only with binocular vision, the squint will appear in a manifest latent squint. But if there is a paralysis, it will be there whether you close one eye or not, paralysis will be there. Okay. But the only problem is that this cannot totally differentiate. Suppose there is a problem with induction testing. In mild weakness, you cannot pick up by induction testing. Suppose imagine that you got a mild lateral rectus weakness on the right side. When you look to the right side, if you view with both eyes, you can find out the mild disconjugation. That means the left eye is moving much more than the right eye. Then you can say, oh, there must be some lateral rectus on the right side. But if you close one and do that, that mild restriction can be overcome by excessive innervation on the part of the brain. So that mild weakness may be nullified or be cancelled out, or you will not be seen. In that case, if you what you see, excess innervation is going to the paralyzed eye, the left eye will be adducting much more than normal. That gives an indirect clue that is got a paralysis. So adduction testing has got that problem. But if it's a large angle heterotropia, definitely adduction test can pick up that pneumatic. Are you getting my point? This heterophoria means squint that is latent squint. Okay. The squint can be manifest latent squint, or manifest means already separated out, but the interocular movements will be all normal. Okay. Latent means eyes are the primary parallel is parallel, but already there is a latent squint which become manifest when the eye becomes tired. Only mild deviation will be there. Okay, this is the adduction testing was done. See the adduction testing. When a closed eye movements are all normal, but you find some nystagmus jerk on looking to the right side with closed eye.
Yes, sir.
There are also some nystagmus, I think, appears there can be seen, but the range is normal, full range of movement. Now let us see the close to the right eye. Our interest eye is the left eye. Full range. Again, you got some nystagmus appearing onto the left side also with closed eye. That was not seen initially. But range is normal. Full adduction. So adduction testing did not show any restriction of ocular muscles. Means that it is either a latent squint which became manifest or concomitant squint, or it may be mild paralysis of the medial rectus. There's two possibilities are there. Now what will you do now? Even though this finding was favoring concomitant squint rather than paralytic squint, this test cannot differentiate mild paralysis. And if you are not for, what is it is correct. What did you say?
Other tests for fatigability, sir.
Fatigue. Other muscles were normal. In fact, upward movement or no complaint on looking up. Complaint was only on looking to the right side.
Ice pack test.
Pardon?
Ice pack test.
Yeah, that you can do. But again, it is even new segment test, ice pack test, and the problem is that there is no objectively you cannot see any improvement because the deviation is so mild. Okay, so whether it's really improvement or not, we are not very sure. So doses and all is very good. Okay, definitely can there is doses is improved. But mild lateral rectus with that too appearing intermittently, see closing one eye, it is not there. It will become very difficult with this testing. Of course, you can do RNS testing and all, which you can do. Okay, now the question is whether it is a paralytic skin or a concomitant skin. That's the first thing. You find some adduction problem. So it was not, by adduction testing, we could not differentiate is a mild paralysis or a concomitant skin. So what is the test designed to differentiate between the two? With the bedside. Cover, uncover test, and alternate cover test. Okay. Is it exotropia or exophoria? And tropia means manifest skin, and phoria means latent skin. So what will you do? You can do two things: cover, uncover test for heterotropia, and alternate cover test for heterophoria. Okay. Let us see the cover, uncover test. This is suppose there is a mild paralysis, real paralysis of the muscle. When you do the uncover test, you can find out the movement of the uncovered eye. When you shift the cover from, when you put the cover and remove it, and put the cover and remove it. So I'm putting the cover on the left side and always look at the uncovered eye. No movement at all. Then I cover the right eye again, no movement.
തുമ്പത്ത് മാത്രം നോക്കുക, വേറെ എവിടെയും നോക്കരുതേ. ശരി. നോക്കിക്കൊണ്ടേയിരിക്കണേ നമ്മ.
Okay, what does this tell you? It tells you somewhat like a concomitant skin. In the concomitant skin means patient fix with any eye she likes. It can be alternate fixate. She can fix with the left eye or right eye. But if it's a paralytic skin, what happens mean? When you cover the normal eye, she's forced to fix with the paralytic eye. When you remove the cover or put the cover the other eye, you find that the deviated eye will come back. That way you can differentiate whether it's a paralytic skin or not by cover and uncover test. So here it is more favoring a concomitant skin. So then this is another video, the same again. You find there is no change in the eye position.
ഇവിടെ തന്നെ നോക്കണേമ്മ, വേറെ എവിടെയും നോക്കല്ലേ. നോക്കിക്കോ, വേറെ എവിടെയും നോക്കല്ലേ കേട്ടോ.
No movement of the other eye.
കാണാമല്ലോ.
You got the point. Suppose she was fixing with the right eye, fixing with the good eye was the right eye, left was the deviating eye. When you put the cover on the left eye, it should have gone back to its lazy position. Okay, when you remove it, it comes back and fixes it. But that movement is not seen in this patient. So I did not see any deviation of any eye. So means there is no manifest skin or a heterotropia. Now I did the alternate cover test. Alternate cover test for heterophoria. There is a latent skin. Therefore, that you have to do. That means latent skin means there is no skin when the patient views with both eyes. Okay, only when you shift the cover from the other eye, only monocularly you find the deviation. Monocular eye only covering with one eye. And let us see what is happening now. Again, I shifted the cover from. Look at the left eye, looking at that. Again, no deviation.
തുമ്പത്ത് നോക്കിക്കൊണ്ടിരിക്കണേ.
If at all mild deviation, the right eye medially towards the medial side. I'll show it once again. Look at the right eye. When you cover the covering the right eye, nothing is happening to the left eye. See now covering the left eye. Now shifting the cover. See mild adduction of the left eye on the right side. Again the same. There was some suspicion of movement of the right eye inward when the cover was moved from the right eye to the left side. However, even if it was there, that would indicate that the fault was on the right eye, not on the left eye. That eye was moving. Suppose what we suspected was the adduction failure on the left side. If the left eye was abnormal, that eye should have moved. But here the other eye is moving. So even if it was there, it would not explain the apparent lateral deviation of the left eye when the patient looked to the right side. Not lateral left eye, no, right eye. That would be indicative of esophoria of right eye. So now I think, are you comfortable with the, are you sure, not comfortable? Are you confident in diagnosing by cover and cover test? I will explain in little more detail how it works. You want the explanation once again? I prepared some diagrams to make it
Yes, sir.
simple.
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
Yeah, otherwise it'll be confusing. I will show this one and then you can look at the patient. It will be easier to understand. Now, what is these tests are to find out for testing misalignment? Cover, uncover, and alternate cover test. To find out misalignment. To find out which eye is fixing, which is the dominant eye. Cover, uncover test is for heterotropia, that is already squint which is present. Manifest squint, which may be due to paralysis. Alternate cover test for detecting phoria. Phoria means there is a squint, but it's not seen. Okay. Cover, cover and cover, you can find out even you can find out in paralysis, muscle all can make out by the only if it is definite squint you can make out by the cover and cover test. The latent which is not seen, you cannot make out by the cover and cover test. That I'll show you in the subsequent diagram. Now, in cover uncover test, the patient is asked to fixate on a distant object, for example, pencil head in the hand. Then a cover is placed in front of one eye and then removed. Okay. Then again, patient fixes with both eyes. Then the cover is placed in front of the other eye and removed, not alternatively covering. You're covering one eye, then removing, cover one eye and removing. That is cover uncover test. So in between, patient is viewing with both eyes. Okay. One observes that always in cover uncover or alternate cover test, we observe the movement of the uncovered eye. Let us see, for example, here on the left side is the left eye, right eye is the right eye. The left eye is deviated on obviously to the inside. Okay, there is an esotropia of the left eye. But remember, this is for finding out subtle deviation. If you have gross deviation like that, you can say left eye is already adducted, there is a squint. But problem comes, there's a mild paralysis. The eye deviation will be so subtle, you will not be able to make out a different or definite squint, just like our patient. That is where you need a cover and cover test. Because subtle paralysis, you are not sure whether it's present or not. So imagine the left eye is the one which is mildly deviated inside, which is not obvious to you. If the right eye was, here what left eye is the affected eye, the fixing eye was the right eye. The right eye was fixing earlier and the left eye was a squinting eye. When you put a cover in front of the left eye, what will happen? Nothing will happen. The right eye remains in the target. Okay, right eye is moving it, that's a fixing eye, that will remain the target. So left eye putting a cover on the left side. Now you take out the cover from the left eye and put the cover on the right eye, what will happen? The left eye, which has already deviated, comes back and look at the object. By movement of that eye, you can say, oh, that eye has already had been little paralyzed. That is why it's made deviated inside. That way you can find out that. So the left eye is at fault now. You can find out by movement of the eye. Okay, you got the point. So that is for, that means he has already paralysis, already there is a manifest squint is there, which you are able to pick it out. Okay, that is for the cover uncover test. Then there can be a squint which is not masked squint. For example, you and all may be having mild squint, but that will not be symptomatic because you have got a functional convergence system which make you, even if eye is deviated, make your eyes align when you do binocular vision, when you want to focus on it with both eyes. Because stereoscopic vision requires image falling on both eyes, so eyes should be parallel. So even if one eye is slightly deviated, your convergence system will come and make the eye parallel. So you may not be seen outside. Your mild squint may not be seen outside. To detect that thing, so the latent, it's called the latent squint or heterophoria, you need cover and cover test. That means cover and then also not cover and cover, alternate cover test. Alternatively cover one eye. Never allow the patient to have a binocular vision. When the patient views with both eyes, the fusional convergence system corrects the squint in case of phoria or latent squint. In such a patient, when you cover the eye with latent squint, the covered eye loses fixation, assumes position of rest, that is latent deviation or heterophoria, and I'll show the diagram. So when you cover one eye, there is no need for the fusional convergence system to operate. The eye in which squint is present goes back into its lazy position. When you shift the covered eye becomes uncovered and refixates moving back. Now, just forget about this statement now. Look at the picture now. Here, what do you do? Just like the other one, patient is asked to fixate an object. Then one eye is covered for at least 4 seconds. And then cover is shifted to the opposite side. The examiner should observe the uncovered eye, just like your cover and cover test. And let us see, forget about the middle diagram. Look at only at the diagram on the left side. See, both eyes are parallel, there is no squint. But actually, left eye has got a squint. But that is not manifest because the fusional convergence system made it set right. So looking at the patient, there is no squint at all. But actually, left eye is isophoric. It's adducted. That is a lazy eye, but which cannot make it out on just looking at the eye. It's got left isophoric. Without cover, there is no squint at all. Okay. Now what will happen? You put a cover on the left eye. What will happen? That eye need not be bothered. It's not ignoring that eye. That is not given a task, look at the object. So it goes into its lazy position. That is a lazy position, isophoric position. Because only when the patient needs to have to view with both eyes, that has to become parallel. When he with that eye, need not look at that thing, that eye goes into a lazy position. Why you want to see it lazy position? That goes into isophoric. So that you can't see because under cover. So you find that there's no movement of the uncovered eye. Now what will happen? You just, without removing the cover, just shift the cover to the opposite side. Then the eye which has been lazy has now shift back to focus on the object. Now it's forced to look at the object. So you can find out the movement. So the eye which moves uncovered eye, that is the lazy eye. Or that is a squinting eye which was not manifest. So now you understood what is the difference between the cover, uncover, and alternate cover test.
Yes, sir.
Yeah. In the first diagram, there is no deviation at all. But in the first one, there was mild deviation, which you are not able to obviously make it out, but you can make it out by just putting cover and removing. You can find out which eye is moving. The eye which moves is the one which has got a paralysis. So I think I'll skip that thing. So coming back to our patient had diplopia, and the time of examination, no definite weakness or restriction was found. Possibly a manifest latent squint, which can become manifest when the patient is fatigued, with prolonged eye strain as in the history. Okay, you agree with the diagnosis?
Yes, sir.
Yes.
Okay, agreed. But I did not agree with my diagnosis.
Nystagmus is a problem.
Nystagmus cannot be explained, sir. Left
Exactly.
is more amplitude than left, right?
It is present on both sides. So that is the thing which is worrying. Everything. So everything was favoring in manifest squint, movement, alternate coverage, everything. But the problem was that because manifest latent squint also manifest only occasionally when the eyes are strained. At a time, you find everything will be normal. That's everything will be normal. At other time, you find that when it's fatigued, when it's become manifest only, you can pick out the abnormality. But even in that case, you should have been seen on alternate cover test, which was not there. Okay, so anything out? Yes, as you already said, it is a nystagmus in the eye, even with the eye closed. See the video once again.
നോക്കേ ഇവിടെ നോക്കിക്കേ
You can find out the nystagmus. Now, question number 1. Can an ocular muscle paralysis produce a nystagmus of the opposite eye? suppose there is a weakness of one muscle, can nystagmus occur in the corresponding yoke muscle? Or nystagmus jugs can occur in the corresponding yoke muscle?
Yes, sir. Because
Yeah.
of the Sherrington's law of equal innovation.
Exactly. What he said is perfectly right. Here also you can find out the human rights. Now, Alice, why should nystagmus like movement occur in concomitant skin? That's why I thought it cannot be a concomitant skin. It is commonly paralytic skin when there is a partial weakness of one of the yoke muscle. But this usually occurs when the patient uses both eyes only. See, this Herin's law of equal innovation, what he said is exactly correct. But when does it come into play? When the patient works with both eyes. Suppose you've got a paralysis of one eye, still it will not be there in the patient viewing with one eye. You understood the point. Suppose you've got both mild weakness on the right side. Okay. We close the right eye, does not move, doesn't matter. There's nothing is happening on the other eye. When you want to view with an object with both eyes, you have to give extra innervation to the paralyzed muscle, say lateral rectus. That extra innervation goes to the contralateral medial rectus. Okay. So what will happen? That I will put is extra innervation in overshooting and coming back. I'll show you one another case I'll show. I'll show you one story. This lady had presented with headache followed by diplopia. In fact, she was going to have you can see it's got what is the finding here? You've got ptosis on the left side, adduction failure, depression failure. It has also ptosis. What is the diagnosis?
Third nerve palsy, sir.
Third nerve palsy. She's got a third nerve palsy. And the pupil is also affected. But what she had actually was a perimesencephalic hemorrhage, not a picoaneurysm lead. And improved with symptomatic treatment. We need an angiodenation aneurysm and all. She improved. And the follow-up video, she improved. And this is the video on follow-up. Medial rectus improved remarkably, but partial weakness is there. But look at the right eye, normal eye. Normally showing nystagmus. See that nystagmus take movement on the right eye. Look at the left side, it is not there. Only on look at the right side, it is there.
Yeah, the left eye is at a lower level. We can take it, ma'am.
So what is causing nystagmus is something new lesion has come up. It was not there earlier on the right eye.
It may be due to minimal weakness of the medial rectus.
Exactly. That is no. How you prove the point?
Monocular adduction.
Yeah,
Monocular.
correct. Exactly. For follow-up, she had remarkable improvement in third nerve pulse, except for the residual weakness of medial rectus. But in addition, she now developed nystagmus to the right eye and looking to the right side. This was not present earlier. What is causing a nystagmus the right eye? That is unaffected eye. Ocular nystagmus. So when she's looking at an object on the right side, she had to put extra innervation on the left medial rectus, being the weak muscle. Her lateral rectus, being the yoke muscle, receives the same degree of extra innervation, according to Thering's law of equal innervation, resulting overshoot of the right eye. Okay, resulting in overshoot mean again your trajectory or command is look at the object. It comes back again because of the extra innervation. It goes back that direction. That goes. So what clinical test to confirm the diagnosis? You look at what did I do? What did I do? Look at the right. I covered the left eye. No nystagmus the right eye. Then remove the cover. Nystagmus appears. Now look at. So that clearly shows that when the patient views only with both eyes, the nystagmus is appearing. If you use one eye, nystagmus will not appear. That means that, what does it mean? There is an extra innervation going only when the patient views with both eyes. Now I want to show you the same video once again to move the point which I mentioned earlier. Now look at not the right eye, left eye when you remove the cover.
നോക്കണമേ അവിടെ തന്നെ നോക്കിക്കൊണ്ടേ ഇരിക്കേ നോക്കിക്കൊണ്ടിരിക്കണേ
Look at the left eye. Not see the eye going inside. See that? Again, I will show once again. Closing eye. It goes to the lazy position now. It comes. It picks up and fixes up the position. Look at the point. That means when you want to look at that, it just got extra innovation going to the medial rectus to make it look at the object. Otherwise, it will go medial, laterally. That is why under cover, it goes laterally.
നോക്കണമേ
I think I'll skip this theory and all. This is the point I'm trying to say. Weakness extramuscular can produce nystagmus when the patient uses both eyes, not with one eye. Same point which I mentioned. So the presence of nystagmus shows that the adduction failure of the left eye is not due to latent squint, and there is indeed a left medial rectus weakness. Now, can this weakness be due to fatigable weakness of the muscle like myasthenia? And myasthenia is one condition which can produce even gaze-evoked nystagmus, and classical pseudo-INO-like picture can occur in myasthenia. I've seen such typical gaze-evoked nystagmus in myasthenia I've seen because of the fatigability and like that. So what test will you do?
Convergence.
Convergence cannot help. Convergence is also voluntary action. The muscle weakness, it will be there. So I did an RNS. RNS was done from the nasalis. That is no evidence of any decriminal response seen in the nasalis and orbicularis. So what will you do now?
Antibody testing, sir.
Antibody testing was done, could be done. I did something else.
Thyroid again, sir. Thyroid.
Thyroid, okay, that's an indirect evidence for myasthenia. That may or may not be abnormal.
Hypothyroid also, that thyroid also can produce.
Yeah, produce, but can produce myasthenia. Yeah, can myasthenia be associated with that? But you have to prove that.
Medial rectus enlargement and restriction of movement.
Yeah, that's different. That's not the one here. This is episodic, not persistent. And duction movement shows no restriction at all.
Neurological test.
Periodostigmine can, again, the problem I told before. No? If you had done periodostigmine with subtle weakness, very difficult to detect. If the patient says diplopia, okay, diplopia improves. But sometimes she's not complaining of diplopia. Sometimes it is there, sometimes it may not be there. So this is what I did. See that. Now let us see. She's asked to look at fast saccade. How do you elicit fast saccade? Large amplitude saccades quickly. Large amplitude saccade invariably become fast. Not like showing a finger in front.
right left right left right left right ശരി.
What did you observe?
Left eye, flexion. Lag.
Okay. Yeah, not only left eye, both eye adduction lag. Now look at the root of the nose. Don't look at the eye. Root of the nose of the patient. And you can see the movement of both eyes simultaneously. I will play the video once again. Don't look at only root of the nose.
right
Then look at the movement of both eyes.
left right left right left right
There is bilateral adduction lag more on the left side. It's actually bilateral INO. So suppose you're doing it slowly with a slow circuit like that. With again, you cannot make out that lag. When you do it quick saccades and fast saccade, then fast saccade only mean large amplitude saccade, you can make out the abnormality. So this is bilateral IN. So initially, the doctor was telling I know what she is exactly correct. There is IN only, but the explanation you have to find to tell this explanation, because what you observed initially was for something like a fatigability, cannot sustain the case. But slowing you can only make out by fast saccade. Now, this is MRI of the patient. Diffusion, normal. What is the commonest cause of bilateral IN now?
Multiple sclerosis.
Yeah, right. This is the flare. We can find out some abnormality in the pons region. I'll show that once again. In T2, in subcortical white matter, you can multiple T2 flare hypertension lesions in the corpus callosum periventricular region, abutting the ventricle like this. And look at the T2 weighted image now. That's a culprit lesion there. In the post, exactly in the site of MLM. There is again multiple white matter lesions, so you can see the corpus callosum and all, you can make it out. That lesion, callosum marginal level, you can find out the lesion there. SW is negative. No. And this is the contrast. Contrast, there is no contrast enhancing lesion. Now, this is the picture showing that multiple flare hyperintensity joining the ventricle. And that's the culprit lesion. You can see the hyperintensity exactly in the region of MLF. And multiple lesions there. Now, last question in this case is, why is that adduction failure is seen only in fast saccades? Like I'm seen only in MLF lesion, not in other pathway lesions. Why?
Sir, the pathway difference, sir. Usually the visually guided circuits, reflex circuits. In OK and tape, usually the visually guided circuits pass to the caudate and goes to the PPRF. Whereas in reflexive circuits, it doesn't go through the basal ganglia, sir.
No, for all saccades, you have to pass through the MLF. Correct? If you do voluntary also, it has got the impulse has go to the MLF only. But why in MS? Why fast saccades is affected first? That is because, see, the MLF is a structure which is the fastest conduction. Why? When you abduct the eye, the same time the left eye should adduct. Without any millisecond should adduct. Some delay means you can diplopia. That is the one track which is the fastest conduction. See, if there is mild lag in the delay in the MLF, you can find out the lag area. Okay. This is why is the adduction failure seen only fast saccades in MLF lesion? MLF is highly myelinated to support the rapid neural transmission necessary for abduction of one eye and adduction of the fellow eye to be nearly synchronous. Mild delay means it will be, again, diplopia will become manifest. Even slight impairment of transmission speed through the MLF produce symptoms by compromising this synchronicity, causing ocular misalignment during horizontal saccades. Because MS, as you know, affecting it's a demyelinating disease, affecting the heavily myelinated tract first. See, a mild degree of demyelination in the MLF will become manifest. That is because that's a tract has got the fastest context. Because both eyes has to go simultaneously. And it has traveled from pons to midbrain. Okay, any questions?
Sir, one doubt, sir.
Yeah.
There used to be, is that statement correct, sir? Like, adduction will improve with convergence in true INO, and adduction will not improve with convergence in pseudo INO, like from myasthenia gravis, sir.
Correct. That's correct. Because in the case of INO, now that's not the reason for exactly. In INO, the convergence is preserved because that does not take the MLF pathway. Because convergence center is in the midbrain, the eyes can converge. And convergence movement, whether it's being convergence or divergence, are slow movement, not rapid movement at all. They are not saccades, they are slow movements. That is one reason. But the reason why it is spared is not that. Cytoablation is entirely different in INO. In superior INO, they can have associated convergence. That's not because of the MLA lesion or anything, because the conversion is also affected. That is the reason.
Okay, sir. Thank you, sir.
Yeah. Any other questions?
Sir, note this
Please.
thing. Like
Yeah.
fast movement is showing some lag. Bilateral lag is there. So can it occur in myasthenia also? It can occur in myasthenia also, no?
Yes, definitely. Myasthenia fatigues. That's why the lag, it appear like a INO, pseudo INO.
So same findings can occur in the myasthenia also, no?
Exactly, it can occur. It can occur. You can also, yeah, I told you, you can even have not only INO, GSO also can occur in myasthenia. Because the abduction is the more effective. Usually the mild rectus is more effective in myasthenia rather than the lateral rectus. But that is more effective. You can have gaze nystagmus also.
What is the mechanism for that?
The same thing, because of the weak muscle mean, you have to compensate it extra innervation to the opposite muscle. The same explanation as Herring's law of equal innervation. One muscle is weak out of proportion to the other yoke muscle. So the brain tend to give extra innervation to the weak muscle. That same degree goes to the other relatively normal muscle. So there is a disparity and overshoot comes. Okay, any questions? In fact, this case, no, I did not diagnose myasthenia as a MS initially. Because I initially thought maybe manifest latent skin because she was reading too much. But I went and thought about why the nystagmus is occurring. I was thinking all along at night, the nystagmus was bothering me again and again. That cannot occur with concomitant skin. That is the reason why I did the fast saccade subsequently in the ward. Then I picked up the IN. That's the clue by which we thought, otherwise I wouldn't have asked for an MRI in this patient. I was about to send her off with convergence exercise and all. Okay, any questions? Anyway, the learning point is that not for the diagnosis, but the squint, how to diagnose mild squint. You have to do the duction testing to differentiate paralytic concomitant. If it's a large angle squint only, it will be useful. Mild paralysis, it can be useful. There you have to do cover uncover test and alternate cover test, differentiate between a manifest latent squint or a latent squint. Then whether there is a paralytic or not, you have to look for the primary and secondary deviation. That part I have not talked to you now. I am not telling you today. Okay, shall I go to the next case? Any questions in this case? Okay, shall I go to the next case? One more case. Okay?
Yes, sir.
Yes, sir.
Okay, yeah. Okay. This is a story of 40-year-old man. This video was sent by Dr. Srinivas from Hyderabad. He presented with episodes of confused behavior associated with dizziness, dysarthria, and abnormal posturing of the limbs for the last 10 years. The episode used to last for 5 minutes to 30 minutes and used to occur with a frequency of 1 per month. Person is fully aware of the episode. The episode used to improve after lying down. This is the video sent by Srinivas. Little confused much of the time. The answers was not quick. Only difficult to get up from the court. And he was unsteady gait.
Say so, but
He was telling some dizzy feeling in the head.
నీకేమనిపిస్తుంది తలగారు అవుతుందా ఏడా ఆయన కరెక్ట్ చేయడన్నా మంచి మాట్లాడు ఏమన్నా మాట్లాడు ఎట్లా
He said some dizzy feeling in the head.
తెలుపన్నాను
He's ataxic and he had no nystagmus on examination. And he went right now.
వేలని చూడు వేలు వేలు ఇట్లా
There is no
చూడు ఇట్లా వేలని
nystagmus in
చూడు
this patient.
చూడు ఇటు చూడు అమ్మలు ఇటు చూడు అమ్మలు ఇటు చూడు
Extreme gaze, there is mild symptoms, but that cannot be counted as nystagmus.
మళ్ళీ మీది చూడు సాగర్ సాగర్ బయటకు నాలుగు బయటకను బయటకను మొత్తం ఇటు తిప్పు అటు తిప్పు కళ్ళు మీ గట్టిగా గట్టిగా కళ్ళు తెరు
No other kind of
పేరేంటిది
weakness.
సాగర్
There is bilateral finger nose incoordination, more on the left side.
మంచిగా
Tandem walking, gait attack says the
ఎట్లా
tandem walking is
మంచి నిల్చో ఫస్ట్ ఆగా దా కూర్చో
mild degree of confusion, increased reaction time was there, no nystagmus, mild dysarthria, bilateral limb incoordination, left more than right, he is ataxia. So what is likely possibility in this patient?
Precipitating event, sir. What is the precipitating event? Either it occurs alone or after some exercise.
No,
Sir.
there is no definite precipitating factor for the event. It occurs episodically.
Family history.
Paroxysmal.
Paroxysmal disorder, correct. No family history is not there.
PNKD, sir. Paroxysmal non-kinesogenic dyskinesia is one possibility, sir.
But this is not like a dyskinesia of that means little shorter duration. This is long, and ataxia is the main problem.
It can be episodic ataxia.
Yeah, episodic ataxia is the thing you have to keep in mind.
Genetic.
So EEG was done, but it is not. It's only not a lot of artifacts there. They're not typical spicoshaploid. It's not there. So MRI normal. What else you need?
Genetic testing, sir.
Okay.
Genome
This is-
sequence.
Yeah, this is the calcium channel abnormality suggestive episodic ataxia type 2. So this is an episodic ataxia. Now I'll show it to he's much better after starting Diamox. Now I'm going to three cases with similar phenotype. These are all my own cases. This 14-year-old boy came with history of imbalance while walking for 2 days. No other complaints. But he used to get such episodes lasting for 1 day to 4 days for the last 1 year. Duration may vary from 1 day to 3 days. This is the finding. She has got downbeat nystagmus. It's a classical finding in episodic ataxia, as well as SCA6. They are allelic conditions.
ഇവിടെ നോക്കി
Got downbeat nystagmus.
ഇവിടെ നോക്കുമ്പോനെ ഇവിടെ നോക്ക് ഇവിടെ താമസിക്കുന്നതെന്ന് പറഞ്ഞാൽ മതി
Yeah, no Pardon?
Any retinopathy was there, sir?
No retinopathy. No retinopathy. Power was normal.
മൂക്കി തൊട്ടെ എന്റെ വിരലിൽ തൊട്ടെ മറ്റേ കൈ മുഖത്തട്ടെ
Finger nose incoordination is there. Reflexes are all normal. And in the interest of time, gait ataxia was prominent. In fact, not very severe ataxia, mild ataxia. So downbeat nystagmus, no dysarthria, minimal finger nose incoordination, severe impairment in tandem walking. What is the diagnosis?
Episodic ataxia.
Episodic ataxia. Again, episodic may be episodic, but we have to rule out unknown serum malformations. MRI was done, which is negative. No ACM at all. So episodic, I thought type 2, he was put on Diamox. And no further episodes even after 4 years on Diamox 200 milligram BD. So the patient was reviewed after 5 months. He had otherwise the nystagmus is almost gone. Gait was also normal. No, genetic test was one, genetic test was negative. It was not suggestive of any channel abnormality was not there. So I sent for episodic ataxia panel gene that was not contributed. So what happened? The patients put on Diamox 50 million, 2 tablets twice a day for 1 year. No further attacks. Dose was reduced to 101 after 1 year. Remained asymptomatic for next 9 months. Then what happened in January 2022, following a fever, patient had recurrent vertigo and vomiting, followed by unsteadiness for next 2 days. And this is at the time of following the fever. He had severe downbeat as well as horizontal nystagmus, mainly a downbeat nystagmus. You can make out the downbeat nystagmus now. He smoked as well as downbeat nystagmus. Looking upward, there is no nystagmus, only side view. Rest of things normal. There is no dysarthria. I'll pass forward. But finger nose incoordination was there. Severe incoordination. And other things are normal. Heel shin test was positive. And this is the ataxia at that time, following the fever. Severely ataxic following the fever. This is a problem with episodic ataxia. Sometimes it can be worsened by concomitant fever or metabolic insult. Admitted and he was tested COVID positive. Then so on switching back, he had complete improvement on Diamox 101, 202, and he was remaining like that without any problem till now. This again is similar case, 23-year-old woman, first seen by me 9 months back. She presented diplopia looking or prolonged reading for 1 year, history of occasional imbalance. On examination at that time, extraocular movement is normal. On keeping the gaze downward, patient complained of diplopia. No nystagmus. Sorry, there is downbeat nystagmus. I'll show the name. First one, there is gazeward nystagmus. There's a downbeat nystagmus. Again, just take the previous one. I think in the interest of time, it fast forward. Can make out the downbeat nystagmus very easily now. She also has got a gait ataxia, very mild gait ataxia. But nystagmus is very prominent. Highly variable presentation. Some people have predominant ataxia, some people have only eye signs are very prominent. She has only mild gait ataxia, unlike the previous one. She got MRI was normal. This is a possibility of kept SCA6 episodic ataxia and serum was sent to SA panel. Again, SA panel was negative in this particular lady. She was also put on diamos and improved with the patient, improved from the ataxia. But the nystagmus did not improve. The ataxia part improved. This is another 24-year-old man, apparently ordained 8 days prior to admission. Following lifting up a weight, he developed pain in the left side of the neck, which lasted for 2 days. 2 days later, he noticed ataxia and oscillopsy. This lasted for 1 day and subsided. Initially, I thought following some dissection or something which produced ischemia to the brainstem. But next he said it's over, everything is subsided. And same symptoms recurred 2 days later. That is what he told. Now, on the examination of the first day, he's got severe prominent downbeat nystagmus. Even looking up, it was severe downbeat nystagmus. And was also, I think, it passed forward. He was also ataxic while walking. And gait ataxia was there. 2 days later, with no treatment, not put any treatment, he improved. This is 2 days later. There is no nystagmus. Occasional mild suspicious nystagmus. Then this is the way he walked. He was perfectly normal 2 days. No ataxia, nothing. So again, 2 days later, again the same nystagmus. So what is the diagnosis? Again, this is most likely to be an episodic attack. In this case, I didn't know the genetic test or anything. This 4 days later, again, he had recurrence. And nystagmus started appearing. And whether not be nystagmus appearing. Okay, so that's the story. So the episodic ataxia can have varied type of personality. Some of them have only eye signs, some with the prominent ataxia. The initial child did not have any nystagmus, only gait ataxia was there and dysarthria. Some of them can have some mild confusion during the episode, being a channelopathy. But all of them responded to diamonds. Okay, any questions?
How does
How to differentiate from vestibular migraine, sir?
Vestibular migraine presents like episodic headache. Now, headache may or may not be there. Episodic vertigo. See, there are 2 conditions which can present with episodic vertigo, lasting for say 2-3 hours, then subsides. Some of them can have associated headache. Some of them may not have headache. Some of them can have associated photophobia and all. If you ask me what is the commonest cause of episodic vertigo lasting for 2 to 3 hours, recurring say after 1 month or 2 months or 6 months interval, it is vestibular migraine, with or without headache. Now, in Meniere's disease, we are talking about, invariably they will associate it either deafness or EEG, the audiometry will show low frequency hearing loss or tinnitus. Without that, you can't differentiate. Sometimes it will be extremely difficult to differentiate Meniere's from vestibular migraine, because even vestibular migraine, the people have described tinnitus is present. But a persisting deafness, if you find it is a clue suggesting it's a Meniere's disease. Now, how to diagnose vestibular migraine is that usually if you got headache and vertigo, of course, it's easy to make a diagnosis. If sometimes the headache may not be there, only an accompaniment of migraine accompaniment may be there. Vertigo associated with, say, photophobia, or sonophobia. Then or heaviness of head, not a headache. Again, it's vestibular migraine. Sometimes no headache at all. They come with episodic vertigo, but no tinnitus and deafness. But in between, they can have headache. Some people will not have in between headache also. Only episodic vertigo may be the manifestation of vestibular migraine, provided the patient will have any accompanying persistent deafness. And a positive family history migraine itself is enough to make a diagnosis of vestibular migraine. Otherwise, if none of the features of migraine is present, it will be difficult to differentiate from episodic vertigo due to vertebral base ischemia and all. But there the duration is little shorter, there will be associated finding.
Thank you.
Yeah. Suppose if an episodic vertigo in a patient and no deafness, interest, audiometry normal, treated as migraine, they will improve. Okay, then shall we stop? Okay.
Thank you very much, sir.
Okay, sir.
Okay.
Good night.
Thank you,
Night.
sir. Good night.
Good night. Next time, next
Thank
week.
you.
Good night. Good
Good
night.
Night.
Thank you, sir. Good night.
Good night. Good night. Good night. Good night.
Thank you, sir. Good night.